Good morning. Or good afternoon, I'm sorry. So when I was in high school, I had a really great teacher at Great Government. He was just the kind of guy that, every student would like to have as a teacher. One day, however, he started talking to us about his Parkinson's disease. He did have that disease. And he told us about his symptoms and, how it affects him, etc. But the thing about him is that he would talk about it so clinically and very stoically that you wouldn't expect him to be a person who does have that disease. But, he did have a very strong character, so he was able to talk about it in that way. One day, however, he was not able to come to school because of his symptoms. And that's the thing with PD, Parkinson's disease. Symptoms sometimes are better, sometimes they're worse. And so he sent his daughter to be a substitute teacher. He was the kind of guy who was able to do that. She came and she told us the lesson plan and everything. And then I asked her about her father, how he was doing. And she said that a few days ago he had watched a movie about Parkinson's disease. And the person in it had an advanced stage of PD. So she said that when he saw him, he was really afraid, because he knew that that's going to be him someday. And when she said that he was afraid, that really struck me, because I just couldn't imagine this teacher who had such strong character being afraid of this disease. That's when I knew that I had to study this more and find out more about it. So I'll be talking about treatment methods for Parkinson's disease. But first off, what is Parkinson's disease? It's a neurodegenerative disease. It's chronic, which means that it's always there, and it's progressive, so it could only get worse, unfortunately, without treatment. The main biological cause is the accumulation of certain proteins called alpha-synucleins and dopaminergic cells of the substantia nigra. Now, the substantia nigra is located over here, as you can see. And dopaminergic cells are cells that produce dopamine in the brain. I'm sure you've all heard of dopamine, and you know that it's a pretty important neurotransmitter. It's involved in many things from motivation to movement to emotion and reward, of course, and many things in between. So once these dopaminergic cells die, that results in an imbalance, a chemical imbalance of dopamine, which leads to PD symptoms like resting tremor, which is pretty much the most noticeable thing when patients with PD move their hands unwillingly, or any part of their bodies, and difficulty with balance and gait. Gait is like the way people walk. And bradykinesia, which is slow movement. And mood disorders. People with PD have a higher rate of depression than non-Parkinsonian people. And sleep disturbances. So in the US alone, there are around 1 million people who currently have Parkinson's disease, or that are currently diagnosed with it. There are probably more who are undiagnosed. And approximately 5% of the diagnoses each year are for people who are under the age of 50. And that's pretty significant, because many of us, when we think of PD, we say, that's something, for later on, I don't have to worry about until I'm 70 or 80 years old. But unfortunately, that doesn't have to be the case, and so it's always something to keep in mind. So treatments for PD. Before the 1950s, there was pretty much no treatment for it, but then this miracle drug, as it was called, was discovered. It's called levodopa, abbreviated L-Dopa, and it really significantly improved the quality of life for Parkinsonian people. And I would say it restores around 70 to 80% of their movement abilities to how they were before their symptoms started appearing. How it works biologically is that it's a precursor for dopamine. It's on the left here, and dopamine is on the right. You could tell, even if you don't know organic chemistry, that they look pretty similar. So it's very easy to convert to dopamine. And when a patient with Parkinson's takes the L-Dopa pill, it's absorbed into the bloodstream, and from there it goes to every part in the body. What's significant about it, though, is that it can cross the blood-brain barrier, which means that it could go from the blood to the brain. And that is something that not many molecules can do. And when it's wherever it is, it gets converted to dopamine through a special enzyme. But we only want it to convert in the brain. We don't want it to convert in other parts of the body, because that would result in very bad side effects. So what neurologists or any doctor does is they usually give the patients with PD another drug called benzodiazepides or something similar. And what these do is that they could also go to every part of the body except the brain. And wherever benzodiazepides are, they inactivate the enzyme that converts L-dopa to dopamine. So that way we could have L-dopa being converted to dopamine only in the brain, which is exactly what we want. The bad thing about L-dopa, though, is that its side effects. Over many years, the side effects accumulate, and it ends up mainly resulting in dyskinesias, which are involuntary movements, and they could sometimes be worse than the disease itself, but you know, it occurs after a very long time, and many patients really prefer these long years of relative stability rather than just having to deal with Parkinson's for all these years. And eventually, Parkinson's itself does get worse than the symptoms they might experience. Alternative treatments, however, the main one currently is called deep brain stimulation, abbreviated DBS. It's approximately a 30-year-old technique, but it's very poorly understood. We know what to do to get the beneficial effects, but we don't know how that works at all. Mainly it is, what happens is the neurosurgeon places stimulating electrodes inside the brain, and these are connected through a charged wire to from under the skin, and they're connected to chargers that, batteries that are placed behind the clavicle on either side. So what these electrodes do is that they stimulate the brain electrically. The surgery risks that accompany it are the same for pretty much any surgery, infection, or risk of hemorrhaging, but they're pretty low and generally not something to be worried about. But the side effects of the stimulation itself, so when the electrodes are turned on, they include lightheadedness, speech and balance problems, and numbness or tingling. They're very minor, and they're very reversible. So once you turn off the stimulation, the side effects go away. And that's really great about it. And another thing is that the neurologist usually works with the patient for around 2 to 3 months after the surgery to adjust these electrodes so that the patient could have maximal symptom relief and minimal side effects. It's been used for many different diseases, PD, OCD, chronic pain, and depression as well. But it's been approved by the FDA as an acceptable treatment for Parkinson's back in 2002. And when we're doing DBS for Parkinson's disease, we place the electrodes in a place of the brain called the subthalamic nucleus, which is in yellow here. And as you can see, it's pretty close to the substantia nigra, which we talked about earlier. And when we stimulate it, we usually see that the resting tremor decreases significantly, and the medication-induced dyskinesia also decreases. Medication primarily being L-dopa. So it could be used as a treatment for the side effects of the previous treatment. Our research. What we mainly do in our lab is in vivo microdialysis. And what that means is that we're able to tell the relative concentrations of different neurotransmitters inside the brain while the rat is alive. We use mainly rats, and sometimes we use mice. So how this works is that we have this very thin glass capillary, and first we insert artificial cerebrospinal fluid, which is the fluid found in the brain. It comes in from this side, then goes down this tube in the middle, and then exits at the bottom. And this thing on the outside, it's a permeable membrane, so it allows all these neurotransmitters to diffuse across it. So when the ACSF goes out here, it goes back up due to the pressure and comes out the other side. But before it does that, all these neurotransmitters are able to diffuse across the membrane according to their relative concentrations, and the perfusate that we collect, we run it through what is called high-pressure liquid chromatography. All that does is just separate all the different neurotransmitters that are present in that fluid. And after that, we run it through mass spectrometry, which basically just allows us to identify which neurotransmitter is which. And we insert these probes in a very specific region of the brain, whichever one we're studying. So in our lab, we stimulated the subthalamic nucleus, and we had the probe, the microdialysis probe at the same place. So that's an example of our results. These are still, we haven't analyzed them and their preliminary results, but I could tell you a little bit about what they might mean, though we're not sure about it. We're not sure about that yet. So these are very important neurotransmitters. I'm sure a lot of you who have taken any psychology courses or MCDB courses might have heard of them. Glutamate, GABA, adenosine, and taurine. Glutamate is excitatory, so the cells that have receptors for glutamate, they usually get excited, which means that they start working more. And as you can see, this blue region, this region that is shaded in blue, that indicates when the deep brain stimulation was turned on. So when we activated the electrode. You can see a significant increase in glutamate concentration. Same thing with all the others. But what we think is happening is maybe an overall inhibitory effect. So you might say, how is that when you have glutamate, which is excitatory? Well, the glutamate might be exciting inhibitory neurons, which release in turn inhibitory neurotransmitters. So the overall effect, even though it started because of excitatory glutamate, the overall effect might be inhibitory. These are just some more of our results. One interesting thing, for example, is glucose. You can see that glucose approximately decreases during the DBS, and what that tells us is that it's being used up, which means the cells are actually doing something more than they did before the deep brain stimulation was applied. Just one more thing. Dopamine, as you can see, increases. L-dopa decreases, which means that it's being converted to dopamine. And yeah, so advancements in PD research currently it's definitely better than in previous years, but it's still phenomenally slow, and that's something we really need to improve. Our research, we're researching DBS, and if we could understand that mechanism by which DBS helps relieve the symptoms for PD, then we might be able to develop better medicines, better drugs, non-invasive ones, that help us treat these symptoms without having to, insert something and insert some piece of metal in a person's brain. The main focus right now, though, in the field is early diagnosis, which helps the people identify their disease earlier and prevent many of the worst symptoms that might occur if the disease goes untreated. So I'd just like to thank Kira for allowing me to present, and I'd like to thank my mentor, Dr. Omar Mabrouk, for pretty much teaching me everything I just talked about, and thank you guys for listening as well. So, any questions?
I have a question about the electrodes used for the deep brain stimulation. I know with neuroprosthetics that scar tissue formation and encapsulation could be a problem. Is that something that you see here, or do they continue working? Do you reject it?
Yeah, that is, especially with the brain, any minor modification could result in really traumatic changes. As I said, though, even the surgery risks themselves, once, if we start seeing that the patient is developing significant reactions to the electrodes themselves, most of the times when the electrodes are removed, the patient stops having these side effects. So not just turned off, but just remove the actual electrode itself and stop treatment. But that generally doesn't occur too much, and most of the time it's not a problem, especially because steel, unlike iron, is more accepted by neurons, whereas iron might cause several problems.
Time for one last question.
Yep.
What is the benefit of using high pressure liquid chromatography over other types of liquid chromatography in research?
Yeah, so I forgot to mention that we actually are, I don't know if I mentioned it, but we're able to analyze between 25 to 30 different neurotransmitters at the same time. And that is something that most other labs cannot do. Most other labs, I think, are only able to do one or two at a time. and only after the animal is sacrificed. But we're able to do 25 to 30 while the animal is alive. So once you have that many different neurotransmitters, then you pretty much have to use high-pressure liquid chromatography, because what distinguishes it is that it is much more precise and gives you much more detail and separation, whereas other different types of chromatography might have, you know, different neurotransmitters coming in the same sample, which is really what we don't want.